All right. Can everyone still hear me?
Mhm.
Good. All right. Hello, everyone. Thank you for joining. My name is Betsy Johnson, and I am the founder of HIM Pros. We do registry staffing. We work with trauma programs, PI coordinators, TPMs. I've been in the field for a little over 16 years. And what we kind of came across in the industry is that there are a lot of things happening. People feel siloed. So, one of the goals of HIM Pros is to kind of connect, collaborate, bring people together, get ideas going, get ideas flowing. So we started HIM Pros, the Pros Network, where we get panelists, we have people that are experts in the field in different areas, get them together. We've been doing it for Cancer Registry the past few episodes. So this is our inaugural trauma episode, and we're calling it Connect, to just kind of get acquainted, to be able to talk to each other, ask questions, bring ideas up, and collaborate. So first things first, I want to let everybody know to keep yourself muted. If you have any questions, you can raise your hand or you could type it into the chat. We will save some time towards the end for open dialogue, and you can unmute yourself at that point. And after the call is over, the recording will be saved on our Pros Network page. So you can go back, you can tell others in the field if they want to go take a look at it. You just have to sign up as a member, and then you're able to see all of the episodes. So with that, let me introduce our wonderful panelists here. First, we have Eric Cohen. Why don't you tell us a little bit about yourself, what you do now, and how you got into the trauma field?
Thank you. Yep, my name's Eric. I am the trauma program director for Maimonides Medical Center in Brooklyn, New York. We are a dual designated adult level 1, pediatric level 2, ACS verified program. We're the only pediatric trauma center for Brooklyn, New York, so we have a very wide catchment area when it comes to pediatrics. Started my career in EMS on the ambulances way back when. Went into ER nursing for quite a while. Was an assistant manager of an emergency room, and have been in the trauma role specifically for about 15 years now. Also, I was a trauma program manager at another dual designated center prior to where I'm at now at Maimonides. But altogether, about 15 years in the trauma game. Um, Very active on very numerous national committees, and I'm just happy to be here.
Awesome, Eric. Thank you so much. And Margie, why don't you tell us a little bit about yourself?
Hello, I'm Margie Young. I'm a PI coordinator. I do contracting. I've done a little, I always say jack of trades. I've done a little bit of everything except for the registry. I probably know just enough to make me dangerous in there as far as abstracting goes. I've been doing it for about 15 years or excuse me, 10 years. I'm thinking of Eric. And I'm just working remote right now, helping other facilities keep their PI caught up.
Awesome. And Robin, what about you?
So I am Robin. I'm happy to be here, and I am the Trauma Registry Operations Manager at VCU Medical Center in Richmond, Virginia. We are a level 1 adult pediatric trauma center and also an ABA verified burn center as well. And I hail from Pennsylvania. I've been here for 5 years, but in Pennsylvania also working for another level 1 adult peds and an ABA verified burn center. I also worked with Eric back at Staten Island for several years. Actually, I was there for 10 years and just recently decided to stop doing that extra work. But I also am on a bunch of committees and do a lot of work with the ATS and TCAA in many different aspects of registry work. And I have over 30 years of healthcare background, with 15 of those now in trauma.
Awesome. Thank you. And Derek, last but not least, you have a cool story. How'd you get into trauma registry?
Well, thank you for having me. My name is Derek Slago. I am a trauma registrar data analyst for Palomar Health, which is in San Diego. And I've been in healthcare for a little over 20 years. Just so happened that I was looking for a new gig and was talking to one of the trauma program directors. and one of her registrars ended up snooping, and so she ended up obviously getting fired. So like I said, I was looking for something new, and it just so happened I was part of a trauma clinic that I started, and she said, "Hey, would you be interested in taking a look at what trauma has to offer for you?" And so I took the bait and ran with it, and been a registrar analyst for approximately 10 years now. Also work with the ATS as well as part of our CSTR mentorship, as well as our trauma registry professional mentorship, chair for San Diego County Registrar Committee, and a couple of things. I've done some presentations for TCAA and TRAM and SDHI as well. So happy to be here and be a part of this connection. So thank you for having me.
Absolutely. Well, as you can see, everyone is very, has varied backgrounds, but very trauma centric, which is awesome. One of the things you guys kind of all touched on a little bit, whether you're an ACS center, how you're designated and how it's different from the state and being a ACS verified center. So I kind of want to dig into that a little bit of, what are the differences with that? And how as a TPM or a PI coordinator or even a registrar, how you kind of navigate the differences. So I know you are also a part-time, you do some verifications as well, Eric, so maybe you can kind of start the discussion off with that.
Yeah, that's another role. I am a nurse reviewer for the VRC. So the American College of Surgeons is essentially the gold standard when it comes to trauma centers and what the requirements mean to be a trauma center. But it's up to your individual state and where your trauma center is located as to, what the rules and regulations about becoming a trauma center is actually dictated by. The American College of Surgeons tends to act as a verifying body, meaning that you're meeting a set of requirements that the ACS has set forward, but usually it's the state that retains the designation power. Some states will rubber stamp whatever the ACS verification is, while other states won't. So as a trauma program manager or trauma program director, whatever your title may be, you really have to understand within your state what are the requirements for being a trauma center. There are states like Texas that require an ACS verification and a state verification as well. But every state is slightly different in how they designate trauma centers, but verification is different than designation. And that's really what the bottom line is, that usually the State Department of Health will designate you as a trauma center. How they do that is up to each individual state.
Yeah. Okay.
Perfect. Oh, don't forget to mute. And then, Robin, why don't you tell us a little bit, because obviously your title is registry operations, so you're doing some management of the abstracting, you're kind of integrated with, the TPM and the whole department in general. What is the difference between, the level 1 to a level 2 facility? And then where does the jump go to level 3 and 4?
Yeah, so level 1 and level 2 are not a huge difference, okay? There's not a big difference. I always think of them as pretty equal. So for instance, even we have a center. So in Virginia, you are designated by the state first as a trauma center and as your level again, and then you are also ACS verified. Now are both level 1 verified for adult and peds for trauma by our state and by the ACS. However, there's another center, one of our competitors, who is a state level 1, but is an ACS level 2. They can't meet all of the standards that the ACS set forward. So, but they're treating the same types of patients, right? So again, I think that level 2, they keep a lot of them. So I kind of put them on the same level. But when you jump to a level 3, then you're kind of in, as far as registry is concerned, and Eric could probably talk better to the standards and those types of things. But in the registry world, a level 3, if I am hiring a level 3 registrar, the good part is they know the basics to the registry, right? They know all of that. The difference is the complexity of the cases that they're seeing. So a lot of level 3s, you'll see a lot of hip fractures or more what I call more of a minor injury. You're not going to get a multi-trauma from head to toe. Those are going to get transferred out to a level 1 center somewhere. So, but I welcome, I at a level 1 center, if I have a registrar that applies that's been a level 3 registrar for 10 years, I welcome that. It's basically just teaching them that the higher complexity, which is not a hard thing to do, in that realm.
Absolutely. And Derek, I know you've done some contract work and you've been at Palomar for a while and you do, some training. I know we'll talk about that a little bit later in the call. But as far as abstracting goes from your perspective, what is the main difference if you're abstracting for a level 2 or a level 3 as opposed to a level 1?
Yeah, that's a really good question. Really, it's going to be based upon the center and what their own internal expectations are. Some level ones do require some additional coding and abstracting as far as like interventions and procedures. Level twos may kind of follow suit, if you will. Level threes, typically a little bit like Robin said, you're going to have the lower complexity injuries, and they may not capture as much data. Some of the other things that we also include, at least at our facility, is we have our county regulated data dictionary as well. So encompassed with the NTDB, those standards, we also have to meet our county collection criteria as well.
Right, that's different. I know not a lot of places have the county difference, so I know California does things very differently in a lot of ways. So
For sure.
And Margie, from the PI perspective, I know you have worked at quite a few different hospitals in different states, and I know we're going to talk about some of these, the guidelines and the things a little bit later. But from the PI perspective, do you find it more challenging if you were at a level 3 hospital, or obviously the cases are a little tougher when you're doing level 2 and level 1, but how is that different for the PI aspect? Oh, you're muted. Still muted. Are you there? Oh, there you are.
Get unmuted.
Perfect.
I think for a PI, the big thing is staffing. As always, I think the complexity of the cases obviously are going to make digging in harder to, not really harder, but more in depth of where you're monitoring things, whether you're looking for an MTP or, digging down for that information and then trying to make those changes in the facilities. But in a level 3, it's not as, you don't have the polytrauma like you do in the level 1 and 2 facilities. And then as far as data abstraction, finding those cases in a level 1, obviously it's an educational facility. So, trying to keep up with all that education information that they're looking to use to make guidelines and policies and changes in trauma in general.
Sure,
So
sure. Yeah,
more
that's
in depth, I think.
absolutely. Kind of to that point, we wanted to talk as well about the differences with, when you're submitting, if you're submitting to the NTDB, there are differences with what you're submitting to TQIP. A lot of places it's separate submissions, there's state submissions, and there's, different cohorts. I know we talked a little bit about this, when we were kind of originally, discussing it. Eric, what do you see with your facility? Because I know New York has some of their own requirements. So how does that look when you're doing data submissions for all the different things, the bodies you have to submit to?
Yeah. So we do have to submit to the New York State Trauma Registry in addition to NTDB and TQIP. I just want to go back for 1 second. When you talk about an ACS verified trauma center, there is no difference in the data from a level 1 or level 2 center. It all goes to NTDB. That is a given. There's a subset of your patients that are selected by TQIP that'll actually go to TQIP, from your NTDB submissions. But again, each state is very different. Our New York State Trauma Registry tends to mirror the NTDB data dictionary. So for us, there's a slight redundancy in submitting to the state as well as to the NTDB, but it's a state requirement, so we do submit to the state. What the state does with that is on the state's hands. But we the requirements for submission are essentially the same as a level 1 and as a level 2, and I believe as a level 3 as well.
Okay, great. And then Robin, for you, how do you handle that? I mean, are you the one doing the submissions? Do you have somebody on your team doing that? What does that look like when you're getting those files ready?
Nope, I do all the submissions. So we also have to submit to our state as well as the ACS. We can submit to our state monthly if we would like to, but we just put ourselves on the same submission cycle as what we do for the NTDB, which is acceptable. Again, the big thing that I always stress is I find when I'm talking to registrars across the country, trauma registry professionals, there are sometimes this confusion between a patient that's submitted to the NTDB and a patient that goes to TQIP. They call them this one in the same. They are not the same. So you're going to find that only a certain percentage of your patients are going to TQIP. So that, depending on your center, could be 30, 40, 50, 60%. It depends. I think usually around 50% is about the average. But again, under the registrars, I think in their beginning training, that's something that's really important to differentiate to them what the difference is. All of these patients that get submitted to the NTDB, the National Trauma Data Bank, will not also go to TQIP. They must meet one of the cohort groups. And again, I think it's really important as you're educating them to show them the benchmark report and explain what it is and explain why the data that they put into the registry is so important to be accurate, because this is the picture that comes back from that data. And it's important that everything be accurate, because if something is off, it may not get pulled into a cohort that it should have. So it's all very important. I think that during education, that's one of the places that gets missed when they are orienting a new trauma registrar. And I think it's super important for them to understand.
So from that perspective, when you are training a new employee, and Derek, you may be able to speak to this too, when you're training a new registrar to do this work, how are you showing them what goes where? Do you have documentation? Is there something in your registry software that says if the patient falls into this category, they have to go to both places? How would a registrar know that?
They won't know it just offhand. There's nowhere that actually tells you. You would have to know all of the cohort definitions, and some of them are a little more complex than others. So we can kind of gauge about who we think is going to go. I have reports in the registry that pull patients based on the cohort definitions, that kind of thing. But for them, what I try to have them think as they are abstracting a patient is they all have the potential to go there. So we need them all to be accurate and correct. So I don't in that way differentiate, but at the same time, I want them to understand that there's a difference, that those are two different submitting bodies. Even though they're connected, they're still two separate. And then your state, and as Derek has, he also has his county, which is something that I've never had to submit, countywide. It's always been, state and national.
And when you find, oh, go ahead, Eric.
I'm sorry, I just want to double back to what Robin said, and the importance of data validation and the accuracy of data. Again, we're talking about TQIP, the Trauma Quality Improvement Program. And again, one of the requirements of being an ACS verified center is that you need to have your data nationally benchmarked. And the only software or the company or organization out there that does that really is TQIP. There are states like New York. When New York got together and we did what's called the New York State TQIP Collaborative. So TQIP is benchmark data. It shows you how your trauma center is doing compared to the rest of the country, your individual trauma center. What New York has done is we've all go ahead and we've entered into a New York State TQIP Collaborative, so we can see how New York State is looking as a state compared to the rest of the country, especially other states that have collaboratives within their state. And one of the first things that we found when we looked at our statewide data was that the entire state was a huge fallout in acute kidney injury. And we found that very interesting, that just that one particular thing, we were markedly falling out from across the country. And that led to our first statewide PI project. And what we did was we actually went back and we re-abstracted all of our acute kidney injuries. Each center went back and took a look at their acute kidney injuries. And I'm using acute kidney injury because that's what we identify. But when you look at the definition of acute kidney injury, if somebody writes in the chart acute kidney injury, does not necessarily mean it meets the NTDB definition of an acute kidney injury. And that's what we were finding was there was a huge discrepancy in the accuracy of trauma registrars across the state. So when we all did this deep dive into our AKIs, and fixed all the errors and resubmitted our data in a subsequent report, because it takes about a cycle or two for you to wash your data out through TQIP. When we got our subsequent report back, we found out that we were actually right on par with the rest of the country, if not slightly better, when it came to AKI. So it just goes to show you the importance of data validation and how it can affect not only your program, but essentially an entire state's outcomes.
Absolutely. And in that specific scenario, are you saying that the physicians were putting in acute kidney injury or the registrars were, or how was that? Where was the disconnect there?
So, and maybe Robin can speak better to this than I can, but, the National Trauma Data Bank gives you very clear definitions for certain things. An acute kidney injury and we've spoken about this offline a little bit. There's a difference in the coding world between coding for billing and coding for, accuracy and trauma registry work. If a physician writes AKI in the chart, that may suffice for billing purposes or back end, hospital diagnosis purposes. But in reality, when you look at the NTDB definition, there has to be documentation of acute kidney injury. There has to be, a certain set of
it's got to be
criteria. Yeah, go ahead.
stage 3. It's got to be stage 3. It's got to be documented as stage 3 AKI. It also there are several things that are or. So there are different criteria that needs to be met, whether that is a creatinine that goes above 4, or if it is 3 times their base when they came in. What was it then? If it was 1.0, it's got to be over 3 times that. The start of dialysis, CRRT, some kind of renal replacement therapy. So there are actual things that have to be met. And I remember this clearly because at the time I worked with Eric as well. And that was one of the PI projects that we did with the registry, and had to go back and educate registrars on the fact that, hey, these definitions, you should have your book out and open. And when you think you see something, you need to check the definition before you apply it. And if you feel like it's too clinical for you to figure out, then you need to direct it to your program manager, one of your PI clinicians, somebody who can clinically look at it and tell you yes or no, it does or doesn't meet. So that's where the registrar, that's where education plays a huge role in educating them.
Absolutely. And can that be part of, when a facility is doing IRR? Maybe Margie, you can answer this. Like would the PI coordinator be doing their version of IRR on the accounts, and would they on the charts, would they be the ones to go back and kind of help with this or find this?
So in the PI world, we do drill downs. So we would run the reports to find those cases that they're finding PI issues with, and then we would do a drill down to validate, does it meet all the criteria? Because then you want to bring it forward and find out if it does, why, or do we have those? And was there a mitigating issue that we need to change a policy or a guideline? So those should be, I try to do, everywhere I've been, I try to do at least a quarterly, but I would prefer to do a monthly. By the time the registry has that month closed, I would like to run that report, look at that information, and get it cleaned up before it gets submitted in the first place.
Absolutely. And Derek, where you're at, do you typically do that as well? I mean, are you sending things to your PI coordinator or your TPM? How do you handle it from the registrar's perspective?
Yeah, ours is a little bit different. For the registrars, we do allow them to analyze any of the PI that we identify. And if it's something that we can close, then we will. If there's, for an example, a dilated cranium and it needs a second set of eyes, then we will forward that to our PI coordinator. And we do have weekly meetings to discuss some of the PI filters. And in the event there's something that needs a past a secondary review, we'll go to a tertiary review, which is going to be our M&M portion, where there's more of a peer review to see if there's any opportunities for improvement there. But from a registrar perspective, for us, we do do a lot of the data validation as well as the PI if kind of at the primary level, and we do close any loop close any of those filters if we are able to do so.
Great, great. Well, that kind of brings up one of our other topics that I thought was really interesting. You know, talking about the care that's being provided to the patients, because obviously, you know, trauma programs, this side of things is more the data, the PI. You know, where can we fix things? And you know, we had discussed one of the topics to talk about was the CPGs, the clinical practice guidelines, and I just thought that was such a, you know, I mean, I'm kind of on the outside of doing the staffing piece of this, but I thought it was so interesting because when you go to a hospital, you want to have the best care and you want your family and friends to get the best care. So, what does that look like? I know, Eric, you kind of brought that up a little bit with the practice guidelines and where the standardization is. So, why don't you talk a little bit about that?
Yeah, I think we're all struggling with that a little bit. It's a new requirement of the American College of Surgeons. Most of us that have been doing this for a while are aware that the standards changed at the end of 2022. The new standards are out, and they're placing a very large emphasis on clinical practice guidelines, making sure that you have, you know, evidence-based practice guidelines for taking care of your patients. But more importantly, how are you going back and making sure that you adhere to those guidelines? And that's very tough, you know, to look at every single patient that comes in. You know, did they have an injury or something that could have been followed by a guideline, and did we actually follow that? I mean, for myself, you know, we have a very geriatric trauma center. We have a lot of elderly patients. That's not uncommon across the country, and we have a very robust geriatric guideline for our patients. But to go through and make sure that each part of that guideline was followed for each geriatric patient is essentially not possible. You know, we take a small sampling and making sure that we do that. And this is where, you know, having strong PI support comes into play. You know, as a trauma program manager or trauma program director, we can't do everything. We just sort of make sure, you know, I always say, make sure that you have, you know, competent people working with you. You need to take time to really invest. You know, that's why when the definition for AKI came up, I don't know, I just looked at the bottom of the screen and looked at Robin because I knew Robin was going to know that. You know, I can turn around to my PI coordinator and say, listen, you know, hey, how are we doing with this metric? How are we doing with that? But I think a lot of centers are struggling right now with how do you actually, you know, track all these CPGs, because we have close to 40, 50 CPGs. How do you monitor those all the time? So, you know, obviously automation in the registry, you know, we've added certain data fields into the registry to help track certain parts of these guidelines. But it really depends on the guideline, how complex it is. Also, you know, is it a population when you start looking at your performance improvement in your PI? You know, where are you having problems when you start looking at your TQIP reports? Where are you having problems? You know, are you having problems? Let's use geriatrics. Are you having geriatrics in your elderly population? Are you seeing bad outcomes in your TQIP report? You know, you're going to want to focus on those guidelines that affect that metric a little bit more as you move forward. If you have a guideline for something that you've had no problem with for 2 years, you might not be paying as much attention to that guideline as to a guideline that affects an issue that's showing up in your TQIP report or in your PI processes along the way. So it really, you know, it's very program specific, and it's program specific in the resources that you have and how you're going to monitor that. Obviously, a program that has 2 or 3 PI people will take less emphasis off of the trauma program manager looking at that. But I think a lot of us are struggling with how do we actually really, you know, make sure that we're adhering to these guidelines the way we're supposed to for the client, for the patients that really need them.
Absolutely. And Margie, when we were talking before, you know, we kind of chatted about, are these standard? Is it the same everywhere? Is every facility different? You know, kind of to Eric's point, if there's different populations at the hospital you're at, how do you as a PI coordinator know what the CPGs are? How do you, you know, take that to the TPM or the medical director and say, hey, what's going on with this or that?
I think first you got to find where, like Eric was saying, when something pops up that it's falling out of out of your metrics, then you want to bring it to their attention. But every facility that I've been in, the first thing I do is I go to the policies and guidelines and review those so that I know when I'm doing PI on those charts what the actual expectations are. And if there's no expectation in the guideline or policy, I'll bring a case or two to tier 2 or to the trauma program manager and just ask, you know, what are we looking for? What is our expectation? I really like everywhere I've been so far, we've been able to initiate a PI dictionary, which I really like that idea, so that everybody's looking at the same thing. They know what they're looking at. Registry knows what PI is looking at. We're all on the same page when we go down to it. And then you just update it as you go so that it can and keep you all on the same page. But then when you see those fallouts, you bring it to your tier 2 and get it looked at and see, you know, tracking and trending, what's going on with them.
Absolutely.
Mhm.
Derek, when you're seeing this from the registrar's perspective, do you, you know, when you go to a new facility, do you have a list of them? Are they documented? How do you find them? You know, we kind of were talking before about training new registrars. How
Mhm.
do people get all of the information they need to make sure everyone's on the same page?
Hopefully the center has their own internal data dictionary, because that is really a key element for onboarding new staff. And then once you allow the one-on-one session to occur, then you kind of allow them to sit in the driver's seat, if you will, and just kind of monitor their progress. But what I have seen is there are subtle differences amongst trauma centers across the country based upon locations or region. For example, you know, some centers may capture snake bites. We don't. So, you know, you're going to have to be center specific depending on where you are working. But then also try to apply what the internal guidelines are in order to make sure that you're capturing the right information, you're abstracting the right data, you're looking for appropriate documentation, and then you're looking at it from a PI perspective as well. Is there a way that I could help kind of drive some of these, like, oh, aha, something's off here. Can I bring this forward? So then that way it's a collaborative effort to make sure that, you know, we're following the clinical practice guidelines, we're following our state requirements, you know, if there's county or even national requirements, we're following those as well.
Absolutely. And, you know, kind of to that point, as far as the loop closure, Robin, in your facility, you know, I don't know, you probably know right now off the top of your head with the gray book, what the new PI requirements are for the patients. How do you do that with the PI nurses? I mean, do they just do it like with date of most recent contact? Do they go by alphabet? How do you break up the number of patients to each PI coordinator?
That's a great question. So we actually have our PI coordinators are called trauma nurse clinicians. We have 4 of those for our adult program. So there's 4 of them. There's myself and then our trauma program manager. But what happens is we do have a weekly PIPS meeting. And so the PIPS patients are pulled by, it could be morning report where something's gone over a patient that came in. It could be a physician, a resident, or one of our APPs on the trauma service who emails. We have an email called titled Trauma PI. So those go to the 4 nurse clinicians, myself, and our trauma program manager. And then we can see what needs to go on PIPS for every Friday and the reason why. Sometimes, like Eric said, it may be something that a guideline wasn't followed. And when we have something, we have a guideline, as we had talked about, for ED thoracotomies, right? So if that guideline was not followed, that's going to immediately go on PIPS. And it may have been not followed for a good reason, but it's going to go on PIPS. It's going to get reviewed. It's going to go in the registry, and whatever that, you know, the closure is on that case or whatever it is. But our registrars actually, as they're abstracting a case, our nurses, our 4 nurses, are out rounding every day. So they're each on a different team. So every patient is being rounded on our trauma service. And so they hopefully are going to pick up any of our audit filters. So those being any of those complications or hospital events, as we now call them, since they may not be a complication, but an event. Those are hopefully going to get picked up in that way. However, weekends, nights, different times that things happen and they don't get reported. So what happens is we have a team spreadsheet, and it's a for every month, and it's an ongoing spreadsheet. So there are certain hospital events and what we call in our system as critiques, others call them just a PI audit filter, that go on that list specifically. So if a registrar identifies one, they put it on that list. If one of the PI nurses identify it, they put it on the list, and then they enter it into the registry. And then when the registrar is doing their chart, it's already there. They can see when they entered it, why they entered it, what happened. If they have questions, they know who to go to. And we follow that sheet so that things are getting reviewed in real time. Our registry is within 2 weeks being concurrent. So like this week's charts will get assigned next week. That's pretty much how we flow. So we're pretty concurrent and staying on top of those PI issues. And again, addressing them in pretty real time. So that's important too, because when you're going back 3 months to look at something, nobody remembers what happened with that patient, right? They're seeing how many patients. So it's really important for your PI to be on top of it. And then we do a double review by at the end of the quarter, I run a list of all of those things, and we split them up between the 4 nurse clinicians and myself, and we actually validate all of those hospital events or RPI filters and make sure that they are actually, before submission, everything is revalidated in that way. And if something is missed, like did somebody miss something along the way? So that's kind
great.
of
It's triple checking, which is really good. Okay, so kind of to this point, I know I'm trying to watch time here so we can save a little time if we have some questions, and then if not, we'll go back to some of these. I know that one of the things that I'm sure registrars, especially, and even PI coordinators, one thing that Derek and Robin are part of right now is, as Derek, I think, mentioned, doing the trauma registry professional mentorship, working on things like updating job titles and descriptions of what people are doing to kind of try to standardize pay and qualifications, and requiring certification. So where do you stand with that, Derek? And I'll have you speak as well, Robin, but what's going on with that?
Yeah, so with the ATS mentorship program, we've already rolled out the program. As far as the trauma registry professional beginner, if you will, there is some opportunities to join, and it is free, so that's great. So if someone's looking to become a trauma registrar, you can join the mentorship program, get an oversight of how do I get started, what are the expectations, what does my day-to-day look like, and joining that program I think is valuable, because if someone's looking for something new, that's probably the easiest way to get acclimated or even involved with kind of thinking maybe shifting from like cancer to registry. As far as the certification, we do also do mentorship group sessions for the CSTR, helping you sit for the exam as well. So this is really going to be anybody who's looking to either expand their knowledge or is looking to become certified, to help them either personally or professionally as well. And also just to be able to collaborate and connect to say, hey, am I doing what I think I'm doing is right? Because sometimes in some centers, you may not have, 13 plus people to ask questions to. You might be the only registrar, and you may not have a PI coordinator yet because maybe you're level 3, and you're kind of on an island. So what a great way to connect and network and ask questions and learn more about your role, whether you're beginner or intermediate or an advanced registrar as well.
Absolutely. I think one of the questions so far in the chat was, I am a cancer registrar. How do I get into trauma?
That's not it. So that's a question you hear a lot. Well, how do you get into trauma? And trauma is really its own little side of the world, really. And like Derek said, our ATS mentorship program is free, but you do have to be a member of the ATS, which still is a minimal. The membership is not very much. I want to say it's like $35 for a year. It's not that much. but you do have to be a member. But that is a great place, because what we do is, not only are you're kind of hooked up with somebody to help mentor you, based on, there's like a questionnaire that you fill out, and then that comes out to all of us, and we're able to then say, hey, I can take this person, or I can, I'll take this person. But every other Wednesday evening, we also do a group session where we actually go over the different sections of registry, with a PowerPoint, and there are several of the members of the CSTR Advisory Council. And so it's really an educational, there's a lot of question and answer time for that too. We will do about an hour presentation, and we stay on a lot of nights for a good hour of just Q&A.
That's awesome. That's a really good resource for people, because I know as you're, trying to get into it, it's especially tough now because people work remotely. So, trauma is a little different, where you still do have people on site. A lot of times the TPM is on site at least part of the time or most of the time. But a lot of the registrars are remote. So it's tougher now. Like I know, Eric, when you had, when you were working at your last facility, you had someone come to you and say, hey, I want to do some trauma. Can I try? And you train this person, you train them from scratch, and now she's great, and she's a registrar. So it's harder for people now.
Then she left me, and then
yes,
went for another
Then
career
she came
path,
to
and
us.
is
Now she's back.
now working for somebody else we all know.
Yes. Well, she's amazing. I love her. But it's harder now as a person trying to look for work, especially after COVID. Because a lot of the nurses and a lot of the clinical staff got burnt out after everything that happened with that. And normally, okay, I'm an emergency nurse, I want to get into trauma registry. We're actually seeing, even in places we are talking to, that the TPMs will not even consider having an ER nurse work there. And I'm like, wait a minute, this is so counterintuitive to me. This person knows all the clinical side. Why would you not want to train them? They went and took the course. And, some of those are expensive, the ICD-10 courses, the AIS course. It's a challenge, because then you go do all this stuff and you get the certification. And now you're like, well, what do I do now?
I'm not quite sure why somebody wouldn't want to hire a nurse registrar. Because the way that I look at it is, if I have somebody, interviewing for a spot, and they have a clinical background, I like that more than a coding background. I can teach someone to code, but I cannot teach them the clinical piece. I can't teach them that. And I find that registrars that I've hired that have zero clinical background do not work out, because they don't understand what's going on. And so I'm not quite sure why somebody wouldn't want to hire I mean, there are places who only hire nurse registrars, right? So I don't understand that at all. I would never say, no, especially an ED nurse. I mean, they have a great clinical background.
Right.
And again, it's looking at finding, if I find someone who comes in who has an extensive coding background, they have no clinical knowledge, all they've ever done is that coding. It's really hard to break them, number one, of the coding rules, because we don't follow the same coding rules as they do. Or, ICD-10 was developed for reimbursement purposes, billing and reimbursement, not for coding for trauma. And so that's why it's also especially important to make sure that your registrars are getting a full ICD-10 for trauma class. It's super important, because again, there are some substantial differences in coding and what we code, especially when you're looking at procedures, for instance. How you would code procedures for billing and reimbursement is not at all the same. And so I find it's very hard sometimes to get them to understand the purpose of trauma, why we're looking at a full clinical picture of a patient by looking at diagnoses, those procedures done to find those diagnoses, and injuries, and then how did we treat them, right? That's what we're looking for. We're not looking to bill everything out. So there's a big difference there. So I do find and I see like Eric shaking his head too, like there's a big difference in that background. So I usually am like, yeah, if someone just has an extensive coding background, I need someone to have, I'd like them to have both, right? But if I have to choose between two, it's going to be the clinical background versus the coding background.
Right.
Yeah, I agree. I mean, I've worked both models. I've worked, you know, a 100% outsourced registry and a 100% my own registry. Um, there's definite benefits to both of them. You know, just going back, you know, I would of course hire a nurse registrar. I think the problem when you're sitting in the TPM seat, you know, we're responsible for the dollars at the end of the day. And there's a difference in the salary lines between registrars and nurses, just base salaries. Um, I do know of programs that have very high budgets for their registries and are able to support nurse registrars across their entire program. I can't do that. In a way, in my personal opinion and from my experience, I would rather go with more registry support of qualified people than just having, you know, saying I have a nurse registrar. I don't think, you know, if you're going to get a nurse registrar, you're going to get somebody that's interested in data. You're probably going to get somebody that's interested in winding down on their career. I mean, this is just from my personal experience. And I don't know if you always get the best candidate by doing that. I would rather go with, you know, using the same amount of money. I would rather go with 5 registrars than 3 registrars and saying that they're all nurses. You know, when I look for somebody, I look for somebody usually with an EMS background. I find those to be very educated people that have enough knowledge on the clinical side, and are usually in a position where they might want to get off of the streets, stop working on an ambulance, and looking for another career path for them to go through with the experiences that they have. Um, but again, that's just, you know, the way I run my program. Other people might have different budgets and run their programs in different ways, but I would always go for the bigger bang for the buck and having more registry support of qualified people than just saying I have a nurse registrar.
Right.
I agree completely with what Eric just said. Yeah.
I think too, it's hard because, you know, if you're hiring someone and they don't have any experience as a TPM or as a registry operations, if you're in charge, you then have to train the person. So it's going to be about a year where you're training, they're learning the systems, the software, what needs to be done here. You know, I think there's certainly pros and cons to both. But it was just very interesting to me because, you know, in my business, we're doing staffing. So we're finding qualified people. Some people, you know, not trauma registrars do not have to be certified to do the work. So in cancer registry, you do. And in coding, you have to have your certification to be eligible to work in certain jobs. But in trauma, you can kind of train people, you can teach them, but then, you know, to your point, Eric, then you're taking away the people who are doing the work that have to now train the new person. And sure, they'll be great when you train them up until, you know, if you don't have the budget for them, then sometimes they're like, oh, we were just talking about this yesterday with another TPM. You know, you train these people from scratch, they then get all their certifications, and then they're like, well, I can work remotely, I'm going to go work somewhere else, because now you don't have to go locally to have a job. So it's a definite conundrum in the industry right now.
I think what Derek, at his facility, they have to have their certification. For us, I have 2 roles. So I have a registrar, and then we have a senior registrar. All of my registrars are required to get their CAISS within 18 months of hire. So they are required. If they don't get it, and we will pay for it 3 times. If you can fail it the first 2, I mean, we pay for it. Even if you fail it, we pay for it. But the 3rd time you have to get it, or you will lose you'll lose your position. And again, you are coding every day with that AIS. You should be able to be certified in that area. And then if you also get your CSTR, then you know, once you have you know, more years of experience under your belt, and then you can move up into a senior role, which is a nice pay grade increase, as well as a lot of new responsibilities and new things to learn. So, you know, I think it's also important for programs to have a stepping stone if you want to keep you're
Yes.
really good
Mhm.
registrars, because if you don't, a lot of times that's when they end up leaving. They're just stagnant.
Mhm.
They want to learn more. They want to do more. They
Mhm.
want to make money. And promoting them, we highly promote and encourage them to get those certifications and to grow, and that's important. And then along with that, you need to offer them something to grow into, right? So I
Mhm.
think that's also important, that other programs should do that. Because when I am interviewing a lot of times from other facilities, that's one of the biggest things I hear is there's nowhere for me to go. There's nowhere to go.
Mm.
They don't care if I have any certifications or not. Nothing happens if I get them. So
Right.
that's something that programs need to look into. Yeah.
Absolutely. It's interesting because, to your point and to Eric's point, the budgets at different hospitals are very different. And, we didn't get to talk about this, but one of the topics we had on our, discussion was, who's in your trauma program? Who do you have supporting you? How supportive is your administration? What doctors are supporting? How is your medical director? Those kind of things are very important with the success of your trauma registry. And, if you don't have opportunity for people and they hit a wall, then you know you have nowhere to go. So it's no surprise when people go into different positions. It happened with Derek, and it just is very, to me, it's a no-brainer. You give people opportunity, you learn, you get more experience, you get your certification, and you get a bump in your pay. It just it's tough for me because I can see that that's the way it should go, but a lot of times administration is so set in their ways on things, and you lose really, really good people because of that.
Mhm.
Definitely. Okay, so I know we are almost to the time here, so I'm going to open it up. If anybody has any questions, they can direct them to any of the panelists. Feel free to unmute yourself if you have any specific questions. Nobody has anything?
Somebody's got to have something.
No.
I actually have a question.
Right.
So I'm newer to the registry. I was an X-ray tech for well, I'm still an X-ray tech for about 8, 9 years. Um, but I still have issues when it comes to the benchmark reports, like understanding them. Is
Mhm.
that something that I can learn through that mentorship program, or do you guys have any advice about?
So we don't really get into the whole TQIP benchmark report because it's not part of, the CSTR or part of. But what I will tell you is, the first place to go is to the TQIP education portal, which
Mhm.
if you're a TQIP center, you should have access to, no problem.
Mhm.
And there are actually a couple of different webinars that explain the
Mhm.
benchmark report to you. And my registrars are required to watch all of those, like when they first start, not right away because they need to work up to having an understanding, right? But I make them every year, the new educational webinar, everything, that is a requirement for them
Mhm.
every year by June, that they have watched all of, anything new. And I refer to them often for them to go watch and look. They have them, all the algorithms for your comorbidities along with your hospital events, and they're really helpful. So
Mhm.
that portal, that education portal, is excellent.
Mhm.
Yeah,
Yeah, that's a great point, because you also can get CEs from watching them as well, and it will definitely tell you how you get to certain algorithms, cohorts, and risk-adjusted benchmarking. So it's a really great tool if you're looking to enhance your knowledge of those reports. And then obviously, if you had any questions, you could probably feel free to reach out to any of us on the panel as well, because I do talk a little bit about reporting and benchmarking data statistic analysis as well. So if you had any specific questions, you can reach out to us too.
I would also suggest, reaching out to your TPM. I guarantee you that your TPM will be very impressed that you came and asking about your TQIP data. I'd hire you tomorrow if you came to me asking about TQIP data and why it's important. I would tell you I'd probably hire you tomorrow because that's the engagement that you're looking for, right? That's when you start putting all the pieces of the puzzle together. That's when you know somebody has recognized what the bigger picture is in all this, right? And I would love for any of my registrars, and we do quarterly sit down and go over, not quarterly, whenever the TQIP report comes out, we sit down as a group and we go over it. So my registrars are somewhat proficient in going over the report. But there's a lot of data in the TQIP report, and there you have to learn, and it's not easy to do by any of the TQIP. They're all great resources on the TQIP site, especially for data entry and accuracy. But learning how to interpret your TQIP report and what it means for your own program specifically is really, the highlight of why TQIP exists. And it's not the easiest report to read. There's a certain nuance to reading it and culling out what it means, for your data, looking at a TQIP report. But my suggestion would be going to your TPM and saying, listen, I want to see what my end work produces. Can you go over the TQIP report with me and show me? And they should be very excited to sit down with you and go, absolutely, let's open this up and show you the areas that you're deficient in or the areas that you're doing well in and why.
I think it's important.
And that is
sorry, to share that with your registrars when it comes
yeah.
out and explain it. Because again, as I said before, if they don't know what it is or why is this data so important? That's the first thing I start off with when I have a new registrar. Even if they have 5 years experience, I still start off with, this is what a trauma patient is, and this is why this data is so important. And I go over every piece of it, where it goes and what we use it for, all the different aspects of what we use it for. But that benchmark report is really important. And I don't expect them to understand it right then, but I want them to see that we do see, you know what I mean? It's coming back to us. So.
And the one thing to keep in mind too is with the gray book, if you are an ACS verified center, they do want you to describe in your data validation and your PIPS plan how you're using your TQIP benchmark reports. So definitely should be something that is a collaborative within your center. Hey, here's our data. Here's how we can drill down to make either subtle or major improvements, because that's what the ACS is going to look for, is how are you using your data to determine if you can make any the needle change. Can you make improvements? Are you making improvements? Are you and how are you kind of, if you will, finding those outliers and turning those negatives and developing them into positives?
Absolutely. That was a great question, Ashley.
Oh, thank you.
Does anyone else have any
another
other
one.
questions?
Actually,
Shoot.
sorry. Hey, if I'm going to be working in a role, then I want to know everything that I possibly can about it. So since this is still kind of new for me and we are kind of growing, we're at level 3. We're trying to get up to level 2 over the next several years. So we are trying to get more staff in. So, we're like working like busy bees, but we do have verification this year in November, and I've never gone through verification. So if anyone has any insights, like what a registrar would need to prepare.
It's going to depend on your facility, and how much they're going to have you involved. As a registrar myself, I was a large part of the PRQ data collection. As far as, since ours also was remote, we had to establish video and filming of certain areas, key areas like our hazmat areas, our ORs. So we had to prepare videos, speak to those as well. So we had a lot of IT components that we need to get involved as far as getting extra equipment, because we had to have iPads to film. We had to have extra microphones, some of those components. A lot of what you're going to look at as well as the PRQ requirements. And you can talk about that with your TPM, because that's really going to drive a lot of the discussion within your center, as far as who can be a navigator, who can be, fill in essential roles that the ACS is looking to go to when they are asking specific questions of your center. How do we get this information? Who's your navigator? Who's your TPM? Who's going to help us, if you will, be appointed to make these decisions while we're going through the verification process?
You know, there's a lot of new people coming into the trauma game, and it sounds like there's a bunch of new people on this call. And I do want to plug the American Trauma Society. They are a tremendous resource for new people. I myself am actually giving a webinar in I think 2 weeks on verification with the new grade book standards. You know, the American Trauma Society, the Society of Trauma Nurses for people that are interested in becoming TPMs. You know, these two organizations, they both have very, very large online chat groups and communities where, you know, all these questions are discussed at length. So for anybody new looking to get information like this, you know, I am going to put in a plug for the American Trauma Society and the Society of Trauma Nurses. I think like Robin said, I think it's like $35 to join the American Trauma Society. But the information that you get out of that is just absolutely invaluable when you log into the communities and you see that these people are asking the same questions that you probably had in the back of your mind for a year. It's very, very helpful.
Just to also say, just so you know, it will be coming out, but I am also doing a webinar for the ATS on April 25th. It will also include, Derek will also be there, our panel from the CSTR Advisory Council, but it is going to be on the TQIP benchmark report and the registry. So anybody who wants to learn more about it, that will be coming out as well. They should be sending that out very soon. We were just actually tying up all of our loose ends yesterday.
That's perfect, Robin. I was actually going to say, if it's not already, it sounds like that would be a good topic. So that actually concludes our time. Thank you so much to all of our panelists for being here and for everyone who joined. There were some questions about whether the video will be available. If you go to the HIM Pros website, go onto the Pros Network, you just have to sign up as a member, and then anyone on your team or anyone you want to share this with will be able to view it. And then once you sign up on the Pros Network website, you'll be automatically added to our invite list for any of our future calls. We are in the works of, you know, figuring out the topic for the next one. We want to make sure this is useful and valuable for everyone. So we will be sending out a short survey either probably tomorrow, just to see what everyone thought and then what topics anyone would be interested in hearing about, because we are super excited. We love this trauma discussion, and I know there's a lot of great stuff to talk about. So thank you all who joined, and hope everyone has a great weekend.
Thanks.
Thanks, guys.
Thanks, Betsy.
Bye.
Hey, guys.
Bye.
Bye.
Thanks, everyone. Enjoy the weekend.
You too.